Wow. So that's it, just go?
Yeah, that's
awesome. So, wow. Like, I'm a person who tries to cultivate humility. That's like one of my core practices. I can't be more humble than I am right now after following those 2 hours of beautiful sharing. Like, I'm mad at Elizabeth, but I'm also as humble as I can possibly be right now. And I like what Cassandra said about, positioning herself. Like, I am a white man, and I'm from Arkansas. Arkansas is the place of all the 50 states that has the highest prevalence of food insecurity right now in households. And so all of that really informs what I'm going to tell you all about today. But I just want to say I'm also going to talk about Western science, colonialism kinds of concepts, all the things that you just showed the limitations of. That's what I got to talk about for 20 minutes between now and you and lunch. So we'll do this together. Amy was going to talk a little bit about GusNIP and the work that we do. It's a national USDA produce prescription program. I'm going to skip through that. She wanted to skip through that because lunch smells really good. So let's zoom ahead on that. That's the place where we work, Gretchen Swanson Center for Nutrition, all over the United States. There are 40 or 50 of us across 30 different states. How many? 55 of us. We're growing every day. And there's always new positions too, so keep an eye on our website. I am based in Fayetteville, Arkansas, like I said. Amy is based in Asheville, North Carolina. We're going to talk about what was the GusNIP Produce Prescription Program. Really quick, just the idea is GusNIP is all about increasing the purchase and consumption of fruits and vegetables among participating households. On the produce prescription side, if you start at the top of that circle, the main thing is it's a screen and refer model across clinics, over 100 different clinics, or 100 different projects across the United States, many of which have multiple clinics in multiple places where food is distributed. So screen positive for food insecurity. You get referred to some resources. Sometimes those resources are right there next door, or right there in the clinic. Sometimes they're at a farmer's market. Sometimes they're at a retail place. Sometimes they're at a community-supported agriculture food box kind of program. So that's how that works. 117 projects. The USDA invests a lot of money in it. Last year, there were about 23,000 people who participated in GusNIP produce prescriptions across the United States. Okay, so my brief today was to talk about what are we learning from the evaluation. My job is to co-lead the evaluation of the produce prescription program across all of those clinics. So you've heard here about how hard it is to sort of wrangle data, and like Mariana and Christina and Susan did a brilliant job of sharing all about that. Like, we have to do that even more, scale-wise. Sorry, I can't talk. I'm trying to keep up with the fact that it's been a long time since breakfast and lunch smells good. So Elizabeth said, just tell them what you're learning about. What's the best dose? What's the best duration? This could be a really short presentation. There's no... So nobody knows. Nobody knows. That's what Mariana did a great job of sharing yesterday. She explained nobody knows. Okay, so nobody knows. I work on this project. I work on a massive project with Feeding America and the Elevance Health Foundation. We don't know. I have 120 different projects that I get to help evaluate. Nobody knows. Next year, we're in the middle of a really cool project that the American Heart Association is funding, where we're trying to identify what kinds of program components are associated with people actually just retaining in the programs, that are just staying beyond one touch point. Because before we can say, does this program work, we need to acknowledge for whom are we even talking about and how many people fall away. And so our first step, something that we're going to be working on until that exact day, is which program components. Is it nutrition and counseling? Is it better in rural or urban areas? Is it food boxes? Is it cards that you can swipe in a grocery store? What helps people redeem the benefits or the dollars or the fruit and vegetables that they're entitled to redeem? So to do the same slide that the EAT team did yesterday, but at this national level, and you don't, I'm so used to being a professor, I was gonna say you don't have to memorize this. Oh my gosh. These are the things that we measure. So like dollars issued and redeemed, like vouchers that go out or boxes of food that go out, number of participants, characteristics of the project, which are what I just said. You know, do they have social workers? Do they have CHWs? Do they have nutrition counseling? Is it virtual education? Is it in person? All of that stuff. You know, who's being reached? How representative is the reach of the project in the geographic area that it's recruiting from? At baseline and follow-up, we do those surveys that the last 2 hours of speakers told us. We're like, oh, that's so annoying. We do those things. Fruit and vegetable intake, food security, self-reported health, satisfaction with the program. How many times did you redeem the program? What was the dosage of the number of food boxes that you got? Things that we're working on right now, multi-site, really cool trial across the United States where we have control clinics paired with intervention clinics to look and see, like, well, what are these effects? Sort of, it's not exactly randomized because of reasons, but we're able to sort of measure this stuff over time, at least a little bit, to say, like, can we compare people who are receiving the program to control groups? We're set up to now start receiving EHR data from clinics across the United States so that we'll be able to look at biomarkers and utilization. We are piloting measures out in the world to ask participants about healthcare utilization. You know, in the last X number of days, did you go to the emergency department? Did you see your doctor for preventive care? Did you have an overnight hospitalization? That sort of stuff. We're also working on the potential of looking at claims data from GusNIP grantees. A surprising number of them tell us that they have access to claims data, which was news to us. We weren't planning to do that until we just were like, you know, does anybody have that? And like 4 or 5 people started to raise their hands. And we're like, okay, let's have a conversation about that. We're also really interested in those produce prescription programs that involve a retail component. What exactly are people buying? They have to buy fruits and vegetables, but which ones? Are they local? Like what are the implications of the kinds of fruits and vegetables that people are choosing to use and redeem their benefits on? And then finally, for reasons that I think Mariana and everybody mentioned yesterday, and for the last 2 hours we've been talking about, we want to do more conversations with the participants to understand, is this working for you in your household? Is this giving you the kind of food that you want to eat in your household? How could this be better? Why did you quit? Why did you sign up in the first place? So that's a lot. So that's what we do measure. There's another conversation, though, that I get asked to talk about a whole lot, which is, well, what should we be measuring? Because some of the things that we measure because they're pragmatic. Some of the things that we measure just because everybody does that. And some of the things are things that we measure because our funders tell us that this is what we have to measure. But if we take a step back and say, well, look, which of those are the things that we should be measuring? What is left off? What should we keep? So I had a metaphor that I was going to talk about, like metrics or like gauges on a dashboard, because Corby is a good writer and he encouraged me to use that metaphor. And I'll talk about it only to say that, like, the person that decides what gauges are on your airplane dashboard or the person that decides what gauges are on your car is the person that decides what you're going to pay attention to and what you're going to think is important. So we'll leave that there because lunch is smelling better and better. So here's some metrics that different groups tell me, and on the projects that I'm on, the teams that I get to work with, what we should be measuring. So the Farm Bill, which authorizes GusNIP, says you have to measure 3 things about these produce prescriptions. Like, it's written into the legislation that includes the funding. So like fruit and vegetable intake should be something that's positively impacted. Household and individual food security is something that should be positively impacted. And healthcare utilization and cost should be positively impacted. And it's actually directional when they talk about it in the Farm Bill. It should be reduced, which has all sorts of implications for communities that don't always have great access to healthcare and utilization, but we usually don't talk about it as reduced, we usually talk about it as improved. So what are the healthcare folks, like the systems and payers, remind us or nudge us that we should be measuring? Here are some of those. Oh, I forgot to note in the last one, like cost and utilization, that was an important theme. Here we see cost and utilization at the top of the list, like they want cost and utilization. I'm really interested in this one thing that we don't have time to talk about today, but it's keeping me up at night, which is, why are we scientists making up new metrics when the healthcare system already has metrics that drive their decision making and their business models? So why don't we have more candid conversations about the kinds of metrics that already are integral to the way our healthcare system operates, rather than us just making up sciencey stuff to measure? So like I've been listening to podcasts about HEDIS measures and quality improvement. And if you're sleepy, like put that into your Spotify. Like just put HEDIS measures in there. Patient quality of life is something that these plans care about. They also care about the satisfaction of their members and their patients, and whether they're going to quit or ask for a different program or plan in the future. Here's another one. The CBOs, which is a lot of folks that I normally get to talk to that are one of my favorite groups. I love you if you're a CBO. Like one of the biggest things that you ask us to think about is reimbursement and how to deal with reimbursement and how to integrate reimbursement with referrals. Like how does that all work together for you? Like where is that working, where is that not working? Those are big topics. When I talk to CBOs in this world, they also say like we're really focused on individual and household food and nutrition security. They also increasingly, and these are the conversations that I love, these are the conversations that we had yesterday with Farmer Donna. I don't want to mess up the names, but yep, back in the back. Like she's talking about these things. We're talking about it with our native communities, our tribal communities today. Like what about this bigger concept of community health and well-being? Like what about the longer term implications of food as medicine? What about the economics for our farmers? Like we want Donna to be able to just retire and put up her feet. She doesn't. Like how can we make sure these programs are having a positive benefit for her? And we also, like, because some of us live in red states, right? We need to talk about messages and metrics that resonate in different policy environments than Massachusetts and California, where we hear all the awesome stuff happening. Those of us in Arkansas and Oklahoma and Kansas, like they don't care, our policymakers don't pay attention to the same gauges on their dashboard as the policymakers in other places on their dashboards. So things like workforce participation, other economic effects are important. I should go back and say, I didn't highlight cost and utilization. That's not something that CBOs wake up every morning worried about, except in the context of reimbursement. Oh yeah, participants, nobody asks them. They don't get to tell us. I mean, you guys do. Like, I'm not trying to disrespect the people at the EAT Project, but in general, people don't remember to ask those folks what they want. Like, I had this epiphany the other day. I was like, man, the only time a lot of food as medicine programs talk to their participants is when they ask them those 2 items on the hunger vital sign, and then maybe they get like an automated survey later from the clinic that says like, how was your experience with Dr. So-and-so today? And that's all that you get. And that's kind of messed up, right? Like we heard that this morning in better ways than I can speak about, and we heard this yesterday in better ways than I can speak about. So I made up those things based on just my experiences and listening to people talk about participants, and the few times I'm lucky enough to face-to-face sit down and talk to participants. But this is what we hear, and my colleague Carmen talked about some of this yesterday, and I think the person from Indiana talked about some of this yesterday. It's like, when you ask people about food as medicine, like what do they want solved in their lives? It's not usually free food. Like that's not usually the thing that's the biggest thing that's on their mind today. So it's stuff like when I go to the doctor, I'm here because I'm sick, so I want to know, like, are these things helping my health? Are they helping, sometimes my blood pressure, is it getting a little bit better? My diabetes numbers, am I able to hang out and play with my kids? Is it, like, I'm worried, I'm a mom, like I don't know if I can feed my kids, and that's stressing me out. I stay up at night if that's gonna be something that I can do tomorrow. I worry about, like, am I paying for rent or am I paying for utilities? Does this program help me get extra money because you're giving me fruits and vegetables, so now I've got money to fill grandma's prescription or whoever's prescription? I think there's also issues around, like, is this program giving me the kind of food that I want to feed my family? And whether I'm living in a tribal community or a rural white community in Arkansas or a black community in DC, like, is this the kind of food, like, as the person who's deciding what I want to eat and what the people around me want to eat, does this work? I also am starting to hear a little bit more about, like, is this extracting? Is this adding? Is this building my community? Like, if we're going to start something here, is this something that's going to make us better collectively? I very much, I hear people say stuff like, really, that's cool, but like, two things. Either they say, I'm here because my kid is sick and like I don't want to talk about Food Security Day. I also hear sometimes people say like Carmen's paper was saying yesterday, and the person from Indiana, like, you know, really employment, housing, like that's the stuff that I want to be talking about. So like this starts to make one of those little warning lights on my dashboard flash a tiny bit. And so like, and I'll tell you why, like, cause I live in scientist land. Do I have time? Oh gosh, gotta hurry.
You're good.
Okay.
The food's not going anywhere.
Good, like, that's what I hear. Yeah, like, one time I was talking to the Urban League in Arkansas, and they said, sometimes you just gotta take the people to church. And like, I think we're getting there. Like, we don't wanna finish too quick. So like, I read this in an online news publication. This was from a national leader in the food as medicine movement. I don't put their name on here because there's a good chance they got taken out of context, but like, I just wanna show this up here. This is something that people say, and it worries me to say that like, food as medicine is not intended to be a charitable program, fair enough, attempting to be reaching patients with the most social needs, but instead to treat disease. That's, I mean, I kind of get what they're saying, but that's not why most of us in this room are in this room, right? Like most of us are not physicians. Most of us are here because we have a history with communities. We have a history with community-based organization. We have a history with food systems. We have a history with healthcare that says like it needs to be done a certain way to improve the lives of the people around us. So that scares me. I was in a call with a national advisory board about food as medicine on Monday of this week, and somebody said, well, you know, this isn't about a food distribution program. I was like, oh, okay. Like I got on the wrong call. And then like one more quick other fact, and then we'll get to then I'll get to say just the same stuff that Mariana said yesterday in different words, and we'll stop. But there was a trial that came out the day after Christmas. It was not a good Christmas gift for the food as medicine scientific community. And what it said was, like this big program run by researchers based at MIT in Massachusetts, 465 patients, what they found was food as medicine helped people's A1C, which is like, that's awesome. That's what we want to see. But then they said, oh yeah, but it didn't help more than usual care, like the normal stuff that you get from going to the doctor. So like the answer to like the take-home message for that is like, everybody got better that enrolled in this trial. Half of them got food as medicine, half of them got the regular stuff that you get from going to the doctor. And so we may have just proved that going to the doctor can be helpful for people with diabetes, which is important, but that's not what we always want to see. And the warning light on my dashboard has to do with that cost effectiveness thing. Because if we're basing our worth to the world on cost effectiveness, and we're not moving biomarkers more than usual doctor stuff, then how does that conversation end well for the food as medicine people? And I think this is not the be-all, end-all study, by the way. Like, this doesn't make me cry. This is just a tiny light that is happening. But I think it's a reminder to us that, like, when we think about food as medicine, like, we don't need to press the fire alarm. Instead, we need to think about like who's in charge here and who's got their finger on the power button. Because I think we in this room have more power than we know in this conversation. But there's good reasons why we're twisting ourselves in knots to try to get healthcare dollars. And so we're in this sort of in-between space right now. And so like this is a graph or a table that I showed to Mariana and friends in Kansas City a month ago. I edited it a little bit. And so like when we think about metrics that I would care about designing a trial about food as medicine for diabetes, like these are the metrics that I think are really interesting right now to a lot of different constituencies. So like per member per month cost, hang out with insurance people enough and they'll talk about that. That's like their favorite story is per member. Like how much does it cost them to pay for your care as a member of their plan? I talked to an insurance person. They said like, you know what other thing drives our attention? If you can cut down on expensive care, like amputations for people who have diabetes, like is a thing like that, way more than can you get somebody to show up at a preventive appointment. Biomarkers important, diet quality, sort of important. Patient-reported outcomes, kind of important. Food security, kind of important. Go down the list, it gets less and less interesting, I think, to a lot of payers and a lot of providers. And one of the things that scares me is like, and I use Ozempic as an example because that's a drug that's real and people have heard of it, but we can make up a fake drug. Like it doesn't have to be Ozempic because Ozempic is real expensive, so it's not necessarily gonna mess with this scene too much. But if your metrics are only about those top 3 things on the right, then like why is your program ever gonna be better than the next drug that comes along? And I think that's the part that we need to pay attention to on our dashboard. Like where food as medicine should win is this stuff down below that yellow box. And so that means when we're designing our studies, we gotta pay attention to that stuff down below that box. And that stuff can be quantitative. It can also be qualitative. That's stuff that you as a healthcare provider or a community-based organization, if you're working on an evaluation, start thinking about that stuff down there. By all means, measure the stuff in the box because that could maybe get you some insurance dollars. But the bottom stuff too is the stuff that I think what got you into this job. And so then people roll their eyes and they're like, oh gosh, this white guy is saying more research because I get paid to do research. So like, oh heck yeah, more research. I don't think that's the call that we have today. It's different research, not more research. So like I'm gonna zoom through these things and then it's just straight up lunchtime. So it's not our job rigorously report on reality. It's not our job to be cheerleaders for food as medicine. It's not our job to cherry pick the best numbers. It's not our job to exaggerate or inflate the projections of the research that we do. It's our job to be honest and find the things that work for the people, for the providers, and for the payers and the policymakers. Like that's what we need to do. Because we don't know what the right dose is, the right amount, the right frequency, the right components, we got to describe who's being reached and describe how your program operates. Is it about pregnant people? Is it about moms? Is it about white people, Hispanic people, black people, rural people, urban people, rich people, poor people? Like who are we talking about here? When we can, we got to add a control group because here's the deal, that RCT that I showed you from MIT, like if we just saw the data from the people who did the food boxes, we would be like, that program is awesome. But what we don't remember is like doctors, nurses, social workers, CHWs are also awesome. When we recruit people from clinics, they're there to take advantage of those amazing services that they're getting. Without any data on controls, we can't parse out like what's happening because they visited an awesome clinic versus they got a food box. Shared metrics where you can use measures that other people use, and that way you can talk the same language when we compare across studies. Qualitative research is vital. We heard all that yesterday. Think about the dose and time frame. You're not going to decrease amputations with a 3-week food medically tailored meals program, probably. And so like think about like how long are you giving people food, and what are the outcomes that should happen if you gave them food for that amount of time. Think about the context in the community. Are you working with Farmer Donna? Are you working with people from your native community growing food? Are you engaging young people from the local high school? Are you building this program out into the world? Are you telling people things that they want to hear about their own communities? And the last one, like keep your eye on costs and claims and utilization for as much as you can. Not every program can do that. Don't tie yourself into not saying like, oh my gosh, we got to get claims data. That's expensive, it's time consuming, it's not even possible for most of us. But think about what you can measure if your goal is to get involved in reimbursement. Like, and those things are costs and claims and maybe biomarkers. But also think about those things at the bottom, because I think your metrics, to the extent that you get to choose them, are literally like, they should be reflective of who you are, your program, your project, your community. You're not going to be able to do that in your office behind a desk without listening to the people that are delivering the programs and the people that are receiving the programs. I want us to be thinking about like, how is this supporting people? How is this supporting households? How is this transforming communities? And like one of the things that I still am as humbled as can be from listening for the last 2 hours, the last thing I will say is that we need to listen to folks like our native neighbors who were here this morning saying like, this is what health means to us. These are the metrics that health is defined by for us. And let's figure out how to help them measure that stuff too. Even if a payer never cares about it, who cares if you're getting money for a program that's not reflective of your soul and your community's essence? So that's all I'm gonna say.
Thank you for delivering. If there's anyone that can stand successfully between a beautiful panel in the morning and a beautiful lunch, it's Chris Long. Let's give him another hand. We gave him a tough job, and I think you got back at me.